Hello and welcome to ANAT-AV. In this video, we will take you through the anatomy of the humerus. We will be focusing on site determination, special features, surfaces, muscle attachments, and finally, applied anatomy. The humerus, a long bone, is the bone of the arm and extends from the shoulder to the elbow. Proximally, the humerus articulates with the glenoid fossa of the scapula, forming the glenohumeral joint or shoulder joint. Distally, at the elbow joint, the humerus articulates at the head of the radius and trochlear notch of the ulna, forming the humeroradial and humeroulnar joints respectively.
Let us now consider side determination. The upper end possesses the spherical head, while the lower end carries the medial and lateral epicondyles. The head is directed medially, upwards and backwards. The lesser tubercle projects anteriorly and is limited laterally by the intertubercular sulcus.
Moving on to the features of the proximal end. The proximal humerus is marked by a head, anatomical neck, surgical neck, greater and lesser tubercles, and intertubercular sulcus. The upper end of the humerus consists of the head. It is about 1/3 of a sphere and about 4 times larger than the glenoid fossa. It faces medially, upwards, and backwards. It is separated from the greater and lesser tubercles by the anatomical neck. The greater tubercle is the most lateral border of the proximal end of the humerus and projects beyond the lateral border of the acromion. The lesser tubercle is anterior to and just distal to the anatomical neck. Separating the two tubercles is a deep groove, known as the intertubercular sulcus. The tendon of the long head of the biceps brachii emerges from the shoulder joint and runs through this groove. The edges of the intertubercular sulcus are known as lips. The surgical neck lies at the junction of the proximal end and the shaft of the humerus. The axillary nerve and posterior circumflex humeral vessels lie against the bone here.
On studying the features of the shaft, we can observe that in cross-section, it is circular proximally, triangular distal to the deltoid tuberosity, and flattened distally. On the lateral side, there is a roughened surface where the deltoid muscle attaches. This is known as the deltoid tuberosity. The radial or spiral groove is a shallow depression that runs diagonally down the posterior surface of the humerus. The radial nerve and profunda brachii vessels lie in this groove. Notable among the features of the distal end are the medial and lateral borders of the distal humerus that form the medial and lateral supracondylar ridges. Immediately distal to the supracondylar ridges are the medial and lateral epicondyles. Both can be palpated at the elbow. The medial is the larger of the two, and the ulnar nerve passes in a groove on the posterior aspect of the medial epicondyle, where it is palpable. On its lower end, the pulley-shaped trochlea is located medially and articulates with the trochlear notch of the ulna. Lateral to the trochlea is the capitulum, which articulates with the head of the radius. Unlike the capitulum, the trochlea extends to the posterior aspect of the bone. The olecranon fossa on the posterior aspect lodges the tip of the olecranon process of the ulna in extension of the elbow. The coronoid fossa on the anterior surface accommodates the coronoid process, and the radial fossa lodges the head of the radius in flexion of the elbow.
Let us now shift our attention onto muscle attachments. At the proximal end, the greater tubercle serves as an attachment site for 3 of the rotator cuff muscles: supraspinatus, infraspinatus, and teres minor. They attach to superior, middle, and inferior impressions of the greater tubercle respectively. The lesser tubercle provides attachment for the other rotator cuff muscle, the subscapularis. Pectoralis major, teres major, and latissimus dorsi insert on the lips and floor of the intertubercular sulcus. This can be remembered with the mnemonic, a lady between 2 majors, with latissimus dorsi attaching to the floor of the sulcus, between teres major on the medial lip and pectoralis major on the lateral lip. Regarding the shaft, coracobrachialis, brachialis, and brachioradialis are touches on its anteromedial surface. The deltoid attaches onto the deltoid tuberosity on the anterolateral surface of the shaft. Posteriorly, medial and lateral heads of the triceps. The spiral groove demarcates their respective origins, with the lateral head above and the medial below it. At the distal end, the medial epicondyle in its anterior aspect provides attachment to the superficial group of forearm flexors and is known as the common flexor origin. The lateral epicondyle provides the site of common origin of the superficial group of forearm extensor muscles.
And finally, arriving at applied anatomy related to the humerus, let us consider a fracture of the surgical neck. The key neurovascular structures at risk here are the axillary nerve and posterior circumflex vessels. Axillary nerve damage will result in paralysis to the deltoid and teres minor muscles. Paralysis of the deltoid results in loss of the power of abduction up to 90 degrees. The nerve also innervates the skin over the lower part of the deltoid, and therefore sensation in this region may be impaired. This is known as the regimental badge sign.
In the event of a mid-shaft fracture, the humerus risks damage to the radionerve and profunda brachii artery. The radionerve innervates the extensors of the wrist. In the event of damage to this nerve, the extensors will be paralyzed. This results in unopposed flexion of the wrist, known as wrist drop, and anesthesia over the dorsum of the hand, in the web between the thumb and index finger. A supracondylar fracture, on the other hand, is a fracture of the distal humerus just above the medial and lateral epicondyles. This results by falling on an outstretched hand. It is more common in children than adults. In this type of injury, the brachial artery can be occluded, resulting in Volkmann's ischemic contracture. This is due to fibrosis and contraction of the flexor and extensor muscles of the forearm. However, uncontrolled flexion of the hand results due to the flexor muscles being bulkier than the extensors. There can also be damage to the median nerve.
And that brings us to the end of this video on the humerus. If you found this video useful, be sure to like, subscribe, and share with your friends. Leave a comment down below. We would love to know what you think. See you on the next episode, and thank you for watching ANAT-AV.